what we hope to be an educational opportunity for you to learn more about your rights when receiving medical care and treatment in the healthcare system. Our focus is on your rights during the COVID-19 crisis. These rights are available to you whenever you are getting medical care from a hospital or a doctor or other provider. The COVID-19 crisis has made it more important for you to understand your rights. This video is produced from a webinar that was held on April 28th, 2020. This educational video came about because of a group of disability rights advocates and organizations are concerned about the way that a possible shortage in medical care and treatment might negatively impact persons with disabilities and pre-existing conditions. The COVID-19 crisis has caused worries across the United States about the possibility of having to make decisions about who will and who will not receive certain medical treatments for more severe cases of COVID-19 or other conditions. Michigan, the state, had not, until April 29, 2020, issued guidance to hospitals and other medical care providers about the need for non-discriminatory guidance on rationing scarce medical resources in the COVID-19 pandemic. On April 24th, advocates sent a letter to Governor Gretchen Whitmer and Attorney General Dana Nessel asking for guidance for non-discriminatory guidance in healthcare, and on April 29, 2020, Governor Whitmer signed an Executive Order 64, 2020 entitled Affirming Anti-Discrimination Policies and Requiring Certain Healthcare Providers to Develop Equitable Access to Healthcare Protocols. The information contained in this video remains relevant despite Governor Whitmer's executive order. It is important that you know your rights so that when and if or someone you care about needs medical treatment, you will know what to do if you are confronted with being told that you or your loved one may not be eligible for certain types of medical care. This webinar is being brought to you by MHAM and Michigan Protection and Advocacy Service, Incorporated, and Jan Latman, who is an independent advocate and consultant. I will provide you with more information about our distinguished panelists in a few moments. Also, I would like to thank the many disability rights organizations and individuals who helped make this session possible and who have been collaborating on a letter that has been sent to Governor Whitmer about ensuring that medical care is provided in a non-discriminatory way to persons with disabilities and pre-existing conditions. Without the collaborative efforts of all these folks, this session would not be possible.
My name is Marianne Huff. I'm the CEO of the Mental Health Association in Michigan. The Mental Health Association is a statewide advocacy organization that works on behalf of individuals with psychiatric brain disorders. We influence public policy and legislation at the state level. We were founded in 1936 and we're concerned with all individuals across all age spans and socioeconomic levels. This is also brought to you by Michigan Protection and Advocacy Service and Jan Latman, who's an independent advocate and a consultant. I'm going to start with our panelists. Our first panelist is Jan Latman, and she's worked in the field of intellectual developmental disability for 35 years, with the past 27 at a local chapter of the ARC. She started as a direct support professional while studying psychology at Saginaw State University. After she got her bachelor's degree, she realized that she wanted to work with people with intellectual and developmental disabilities. She's managed group homes, and she's been an employer of record for individuals living in their own homes and was the executive director of the ARC of Midland. She's been working as an independent consultant. She also works with the Developmental Disabilities Institute at Wayne State and does a lot of training of folks who are interested in becoming independent facilitators of person-centered planning. She's working in the areas of self-determination and supported decision-making.
What I wanted to start with this morning is sort of framing what the issue is that we're going to be talking about, which is people's civil rights and individuals with disabilities' rights to equal access to health care and equal treatment when they are in the hospital, equitable treatment when they are in the hospital. And so I wanted to start by just sharing what some of those rights actually are. In my years of working with people who experience disability, fascinatingly, often folks don't realize that they have a right to some of the things that we're going to talk about today. And also often medical professionals don't understand those rights either. And so it's really important that we know what our rights are, so that if we are in a situation where maybe we're not getting what it is that we need, we can advocate for ourselves. So the first thing is that we all have a right to equal access to healthcare. We have a right to go to the doctor. We have a right to get medical tests that might be necessary for us, which is the next thing I wanted to mention, is that we do have a right to equal treatment options as people who do not have disabilities. Maybe some of you think, well, of course, this is obvious, except that I have to tell you that there have been many, many times when I've been accompanying someone to a doctor and they're having some symptoms that would indicate a certain kind of medical test. The big one is colonoscopy, for example. And so, we'll say, well, gee, they're having these symptoms. This person would really like to have a colonoscopy. And the doctor will say something back like, well, what would you do if you found cancer anyway? Or make some sort of comment that would indicate that that doctor doesn't believe that this individual, that their quality of life is such that it would be necessary to try to prevent that cancer or try to treat that cancer if there was in fact cancer. So people every day before COVID-19 have been denied equal access to healthcare and equal treatment as their peers who do not have disabilities. That's why it's important for you to know you have those rights. You have the right to tell the doctor how you want to be treated. We're hearing some sort of scary stories about people like whole group homes being sent a DNR form for all of the guardians or representatives to sign on behalf of those individuals that live in that group home. And I have to tell you myself, I've been in an emergency room with someone where there was a lot of pressure put on the person to sign a DNR form. So you have the right, though, to tell the doctor what you want and what you don't want. Sometimes medical professionals assume that you as the person with the disability don't have a say, and I'm going to tell you that you do have a say. Even if you are a person who has a guardian, there is an ethical imperative that you get to have a say in how you are treated and what direction your treatment goes in. You also have a right when you're at the hospital, and this is kind of a big one right now with COVID-19, because I'm sure you're hearing that, or maybe you've had some experience where you've gone to a hospital for treatment and they haven't let anyone else in the hospital with you. If you have a caregiver, that caregiver has had to wait in the parking lot, or if you have a patient advocate or a family member with you, or even a guardian, they've had to wait in the parking lot. Truth is, you have a right to have someone with you that you can speak to and that can help speak on your behalf if you need that kind of assistance. And that's, again, another one of those big issues right now in the current pandemic, because they're trying to reduce the number of people that are entering in the hospital, right? And so folks have been told that they're advocate that can't be at bedside with them. And I can tell you a story real quick that happened just a few days ago. A gentleman who is nonverbal, he doesn't speak, he has an intellectual disability and does not speak, and he was having some pretty serious symptoms. And so he was taken to the emergency room, and the person that speaks on his behalf, the person that understands his nonverbal cues and the person that knows him and knows what's typical behavior and not typical behavior, was not permitted into the hospital for over 2 hours. And so he was in the emergency room with literally no one. They finally only let the caregiver in because they realized that they had no idea if what they were seeing was like how he was typically, or if it was a symptom of the ailment that he went into the ED with. So they finally, in fact, let the person in. But you have the right, if you need them, to have someone at your bedside. And what we're recommending and what we're advising people is to make sure that you identify who that person is and that they are a part of the treatment team. Because if you look at the language in executive orders about not having visitors in the hospital, it does talk about members of the treatment team being able to be at the hospital. And so I'm telling families to write in their person-centered plans who are the members of the treatment team that need to be with someone when they're at the hospital. And also, if you have patient advocate forms of any kind, which everyone should have, you want to also indicate that in there. And so at the beginning of this whole time frame where we're not allowing extra people in the hospital, I happened to be accompanying a gentleman at Henry Ford Hospital who was having cancer surgery. He had surgery, believe it or not, on the day before they did the lockdown on the hospitals and made all the visitors leave. And so here he was, still in the ICU, having had surgery just the day before. They were debating whether I was going to get kicked out of the hospital or not. Ultimately, they realized that I needed to remain, and they viewed me as a member of the treatment team. Advocating for that and pushing for that helped them to understand, right, that that was his right, and that in fact it was necessary for him to be able to successfully get through that hospital stay. We ended up there, by the way, as a sidebar for 9 days, and I never left the hospital room for the entire 9 days. And that's pretty much typically what would happen. So if your advocate comes with you, that person better plan on staying with you the whole time you're there. You also have a right to have, if you need personal care, so let's say you need help with eating or other kinds of personal care activities, typically every day when you're home, you also have a right to have that care provided to you when you're in the hospital. Now, prior to this current crisis, if you were on Medicaid, that would not be something that you couldn't bring your community living support staff in with you and expect that staff to be paid, because the idea was that the hospital's getting the Medicaid money, so the hospital has to provide all of the care. However, there has been a waiver requested from the federal government to waive that requirement. And if approved, then a person would actually be able to have their own regular home staff in the hospital with them to provide that care. So stay tuned on that, on what that one actually ends up looking like. We have to wait until that waiver is approved and the state has figured out how they want to actually handle that. The other thing that you have a right to is if you have a service dog, believe it or not, you have a right to have your ADA service dog or any other accommodation that you might need. One of the things that people, and I don't know if Kyle will talk about this a little bit or not, but one of the things that people who use a ventilator at home are very worried about is what will happen when they enter the hospital with regard to their ventilator. You may have heard, like, people are talking about, will they let us keep it? Will they take it? Will, what will happen to me if I already use a ventilator and I have to go into the hospital? What our position is that you have a right to all of the accommodations and devices that you already need. So here's what hospitals can't do. It can't refuse to treat you because you have a disability. Absolutely not. They also can't place you on a lower priority. So let's say, and Kyle's going to really get into the detail of this, but let's say there's not enough hospital rooms, right? And so somebody's going to have to not get a hospital room. They can't put you lower on their priority list just because of your disability. There might be other reasons that you're not as high of a priority as someone else, but they cannot use your disability as one of their criteria for determining where they put you on a list of priorities for treatment. They also cannot discriminate against you for having a disability, nor can they discriminate against you for your race, gender, health status, sexual orientation, or sexual identity, any of those things. What happens though if you feel like you have been discriminated against, or you are being discriminated against, or you need some advocacy, you just need some help and some advocacy? There are some great organizations around the state of Michigan that are here specifically to help people when they have those situations, one of them being Michigan Protection and Advocacy Services, which is where Kyle works. And that is an organization that, that's their whole purpose, is to provide advocacy to people with disabilities, making sure that their civil rights are maintained. There's also the Michigan Department of Civil Rights. If you're looking for like that direct hands-on advocacy that can maybe, before you have to get to those legal remedies, your local centers for independent living, your local ARC chapters, your local aging organizations, if you are a person that is served in that population, are some great starting points. If you don't have a local ARC chapter or a local Center for Independent Living in your community, there are state chapters of those organizations. And again, you still always have Michigan Protection and Advocacy and the Department of Civil Rights. That's, in a nutshell, what your rights are as citizens in this state and in this country, regardless of disability or no disability. I'm going to ask if anyone has any questions for me with just this sort of broad stroke overview.
Here's one. It says, I'm interested in knowing if anyone has had a bad experience and what that was. When I brought this webinar up, there was comment that healthcare is behaving completely ethically. It says, I am a parent who holds healthcare power of attorney for my adult son with autism. He is minimally verbal. Would I be allowed in?
So yes, so the gentleman that I was at Henry Ford Hospital with, I am his power of attorney. I'm not his guardian. I am his power, I'm the power of attorney for medical. That's it. They did in fact allow me in. I was able to make clear to them the reason why, right? Number one, I was written into his person-centered plan. Number two, his power of attorney documentation and his patient advocate documentation really laid out why he needed me, why he needed to have someone act on his behalf in that way at all times. So I was able to use that documentation to sort of convince the folks at Henry Ford that I was a necessary person. I also had a relationship with the doctor, and with, Izzy and I both have a relationship with the medical people that were working with us because he's been battling this cancer for over a year, right? They already knew how critical having me there was for Izzy, for his well-being, right? So it wasn't a big sell. The situation that happened a few days ago was a little different because that gentleman, he didn't really have a relationship. He was going into an emergency room where he'd never been before, right? It was a little harder for the caregiver and the advocate to get into the room with him. But ultimately, after 2 hours, they were able to do that. We're suggesting that yes. So the long answer to your question is yes. As mom and power of attorney, you should be able to. I want to also respond to the statement or question about when somebody brought up this webinar and they said, well, of course the hospitals are behaving ethically. I don't think we're suggesting that anybody's going to behave unethically. In my 35 years of going into hospitals with people and going to doctors with people, is that we all have unconscious biases. We all have pre-existing notions of what is a good quality of life. I think that when Kyle explains what triage looks like in a situation where there is a shortage of supply, it can become really easy for the person who appears to be sicker or appears to not be as capable of recovering, let's just say, to be the one that gets put on the lower priority, right? And we are trying to just make sure that people have the tools and the resources and the words they need so that that doesn't happen to them. Not because people are being unethical, not because doctors are being unethical. Oh my gosh, my sister-in-law is a nurse who is working in New York City right now. I can tell you, nobody there is acting unethically. Patients are sitting in hallways and patients are not getting, prompt, quick treatment like you would hope for every single day.
We have Kyle Williams, who's an attorney and the Director of Litigation Strategies at Michigan Protection and Advocacy Service. Kyle is involved in many areas of disability rights law, as is his organization, Michigan Protection and Advocacy. MPAS is committed to protecting the rights of individuals with disabilities.
Thank you, Mary Ann. Thank you, Jan. Just as a quick refresher for anybody or for those who haven't heard about my organization, I'm an attorney and the Director of Litigation over at Michigan Protection and Advocacy. We're a federally designated protection and advocacy service that provides legal and advocacy services throughout the state of Michigan for folks with disabilities. There's a protection and advocacy in every single state and territory, including Puerto Rico and Guam. We're funded primarily by 9 federally mandated programs that cover type of disability, as well as a program that will assist people in getting back to work, as well as assistive technology needs. Our services are free, our services are confidential, and we hear from about 6,000 people a year with disability-related issues. So whether you're a person with a disability, a family member, or a friend, please feel free to contact us if you do have any questions in the future on disability rights issues. I am going to attempt to describe here today, and what my kind of goal is that everybody can leave this presentation with a better understanding of what medical rationing is and how it affects you as a person with a disability. So that's whether it's you as a person with a disability, a family member, an advocate, a friend, to have a better understanding of what medical rationing is and what your rights are in that context is really the goal of what we're trying to do. So really, we're trying to first have everybody understand what triage is and how triage works in an emergency situation, gain a basic understanding of how medical resources are going to be allocated and reallocated in the event of an emergency, specifically in the state of Michigan under our current guidance, as well as being able to identify potentially discriminatory aspects of hospital policies, that ultimately every single hospital will have their own individual policies. So we're hoping to give you some tools and things to look for if you are faced with an individual hospital policy, and be able to identify some things that may be problematic for somebody with a disability. And then in addition to that, we're going to go over some really specific guidance in Michigan so you can understand where you stand as a person with a disability in the event of medical rationing. Before getting into it, I think it's important just to give a brief disclaimer. This is an upsetting topic to a lot of people, that ultimately, whenever there are limited resources in a medical context, then doctors are literally making decisions on who lives and who dies. This is relatively heavy as a topic, so just forewarning, we are going to be covering some pretty sensitive issues. So I think the first step in getting to medical rationing is understanding the concept of triage. Triage is medical system where they determine the degree or urgency of wounds or illnesses, and then they assign priority on how they're going to treat those various illnesses or wounds. So this is something that happens on a day-to-day basis in hospitals. This isn't something that is unique to emergency situation or a pandemic situation like we're currently undergoing, where the principal goal of a triage is going to be that you're going to be able to prioritize care for the folks who need it the most, while you have your ultimate goal of trying to provide the best medical care for all the patients that are going to present into your healthcare. So there's both micro and macro applications to this concept. On a micro level, this can be department specific. If you have a limited number of ICU beds in your hospital and you have a large number of critically ill individuals, then you are going to have a need for triage to prioritize those who are most severe in order to place those folks in those critical beds, and then have policies and procedures in place for what you do with that overflow. So ultimately, the most sick people are going to be able to get that most intensive care, because but for that care, they could have serious health consequences. Being able to identify what those instances are and then prioritize that group of patients accordingly. There's also a macro application. So this is what we talk about in the context of a pandemic, where we have a limited number of hospitals in the state, we have a limited number of beds. If the amount of individuals who need those beds surpasses what our capacity is as a healthcare infrastructure, then you're going to have to triage those patients and make a determination on who is the most severely ill, who needs the treatment first, and ultimately make a decision on who is not going to get treatment or get treatment at the level that would be best or medically recommended for them in that particular instance due to just capacity issues. Triage is an extremely important concept in the context of an emergency, because we are not able to prepare for disasters or unforeseen events. And so sometimes a hospital system can become overloaded whenever they're going to see a large influx of patients over an extended period of time. So some examples that we see that in our society would be an earthquake in California, forest fires, terrorist attack, or war is always a good example of where your medical resources may not be sufficient to address the particular capacity over a period of time. The concept of triage has really been around for hundreds and hundreds of years. But as far as the development of the systems and procedures, our system and our procedures for triage became much more developed after the Korean War. So for those of you familiar with the show MASH, that was about a mobile army surgical hospital. And this is where the concepts of triage really started to become very developed, and specifically developed in the context of emergencies. And what they did in a MASH unit is that whenever a patient would come in and present, they would assign you to one of four categories. The first and the least severe category would be an instance where minor scrapes and bruises, you need minimal medical assistance. And that's probably an instance where if you do not receive medical assistance, that you will not suffer any very severe consequences. They have a second category that's going to place people who need medical attention. They need it. They may have bad outcomes if they do not get it, but they have a little bit of time in order to get it. So they can be deprioritized and maintained so they can be addressed later and still not suffer any major medical consequences as a result of the delay. There's a third category where people that need immediate attentions. These are your a leg has been blown off, or very, very serious injuries that if they're not addressed immediately, then there will be negative healthcare consequences, whether it would be death or just long-standing severe injury. They need to be addressed immediately and they are prioritized. And then a fourth category where people who are either dead or people who cannot benefit from treatment. So by labeling people and doing that baseline prioritization upon admission for all of those folks, those MASH units were able to prioritize and try to save the most lives possible by not wasting their resources on both people who could not benefit from it and people who did not need it in that immediate time, so that they could focus on using the medical resources for the most emergent need under the goal that we're trying to save as many lives as possible. So with that brief explainer, let's talk about medical rationing and what that is. So medical rationing, simply put, is whenever medical resources are scarce and demand is high, and ultimately a healthcare system will be faced with the decision of who is going to receive medical treatment and care whenever there is a larger pool of people that need it than resources available to provide that need. Medical rationing can happen in a number of different contexts. We talk about it a lot in ventilators. You hear a lot in the news about ventilators and not having enough ventilators and how important ventilators are to treating your COVID symptoms. So ventilators are kind of the classic example of medical rationing, that if you have 50 ventilators and you have 100 people that need a ventilator in order to survive, ultimately that healthcare system is faced with making a decision on who gets a ventilator and who does not get a ventilator, which is very concerning for somebody with a disability, because people with disabilities can be discriminated against and deprioritized solely based off of that disability. The concept also applies to staffing. If you have a number of doctors and nurses in your hospital, you can only provide care to so many people with that amount of staffing. So there are limitations from just a healthcare staffing standpoint point that could have medical rationing apply to that, as well as space. So the number of beds, you can only serve so many people that you have space for. And we see this really on a day-to-day basis with vital organs. There are long lists that people wait for in order to get kidney transplant. There are blood banks that have finite resources as blood in order to do blood transfusion. And so with the kidney transplant as an example, you see that people that have a non-emergent need for a kidney get placed on waiting list. Whereas people with an emergent need, where if you do not get that kidney, you will die, are going to be able to jump that list. And so you can see a triage concept being applied to a kidney transplant or a kidney waiting list. Even though it is not an emergency, it's a finite resource. A lot of people need it, but they have to prioritize who gets it, you get it, based off of medical rationing. How are the hospitals deciding how to use limited resources? And there's a couple of places you can point to that are going to provide the hospital guidance on how to make those difficult decisions. The first one would be state guidance. States can provide guidance, either mandatory guidance or non-mandatory guidance, or choose to not provide guidance at all to their healthcare system. In Michigan, we have non-binding, non-mandatory guidance that's given to hospitals so that they can formulate their own policies on medical rationing, so that in the event of medical rationing, if it does occur, they have policies, they have guidance that can be implemented so that whenever they're making those difficult decisions, they have some sort of guidance that they can rely on in order to make those choices. So you look at the hospital policy. All hospitals should have a policy or a draft of a policy for the pandemic, how they're going to address medical rationing in that facility. Hospitals each have ethics boards. And so these are groups of healthcare professionals that are consulted with on decisions with regard to life-saving treatment and any, number of ethical issues that may present itself in a hospital. But these boards will obviously be consulted with in making determinations of who gets a limited resource whenever there is a resource scarcity issue. That's another place where hospitals are going to receive some guidance on the issue. So whenever you're determining who's going to get limited medical resources in scarcity, there's obvious moral and ethical considerations that need to be considered. We're not going to cover that so much in this particular presentation. However, there are a number of legal considerations that need to be considered, especially for somebody with a disability who is entitled to certain legal protections on the basis of being a part of that protected class. No guidance or policy on medical rationing can discriminate against a person with a disability because of their status as a disability. Just to elaborate on that a little bit further, there's three primary laws that are going to support your right to not be discriminated against for your disability. That's the Americans with Disabilities Act, Section 504 of the Rehabilitation Act, as well as Section 1557 of the Affordable Health Care Act. So those are your federal protections that are going to provide your right to a reasonable accommodation in the example of the ADA in Section 504, and protect your right to not be discriminated against. And those two concepts are probably the most important concepts to understand, is that you have these rights to not be discriminated against and to have a reasonable accommodation, and you have those rights on the basis of your having a disability. Here are some examples of medical rationing policies that are problematic. And let's start with the worst one first. I think a lot of people have heard about this particular policy, but just to go over the specifics of why it is particularly bad, is Alabama had a ventilator triage guidance that the state had released and given to hospitals in order to guide them on how to make decisions on resource scarcity or medical rationing in hospitals. And what they said is that in the event of rationing, hospitals are ordered to not offer mechanical ventilation support for patients with severe or profound mental retardation, moderate to severe dementia, and severe traumatic brain injury. So in other words, if you are somebody with an intellectual disability, somebody who has been diagnosed with moderate to severe dementia, if you are somebody who has a diagnosed TBI, you are going to be immediately deprioritized based off of your designation as having one of those disabilities. So this is what we would call facial discrimination. It is very plainly discriminatory. It singles out people explicitly based off of their disability and deprioritizes them in the event that there would be rationing. So ultimately, you could not hold the position that all lives are equal and have a policy that openly discriminates in this fashion. This was found problematic. My sister organization in Alabama, as well as a number of other attorneys who practice in this area, have filed a complaint. And I'm happy to report that this language has been removed. And at present, Alabama is working on creating some better guidance to advise the hospital system in Alabama on the event of medical rationing. The good news is that that is gone. That is probably the worst example that there was nationally. And so that is very good to see that OCR was responsive in getting that taken care of. Another example is Washington State's resource allocation principles and guidelines. So the problem here is that it prioritizes younger and healthier people over older people for resource allocation. The way that it does it is and it can also discriminate against people with disabilities because it advises doctors to consider baseline functional status. So they're going to consider loss of reserve energy, physical ability, cognition, and general health as a factor in resource allocation decision. This example is not inherently or facially discriminatory. It does not identify a specific disability and deprioritize you based off of your designation as having that disability. However, it does have a discriminatory effect because if you talk about considerations of baseline functional status, that is going to give those folks who may, require oxygen before they present to the hospital, may require community living supports, or, may even use a wheelchair in the example of physical ability, you're going to be deprioritized based off of those individual factors, and those individual factors will have a discriminatory effect on people with disabilities. So even if you don't say it out loud in these policies, you can look for language like baseline functional status and see how doctors are considering that. And it's easy to see how there can be a negative impact to somebody who may need support or have medical needs in the community setting whenever they're presenting to the hospital and becoming a patient of that healthcare system in a resource allocation situation. Here are a couple of things that if you look at a hospital policy on medical rationing, these are some tools that you can use to identify whether or not you're going to have a problem with this policy or whether it could be potentially disruptive. But these are some of the things that you can look for in both state guidance or hospital policy to try and make a determination of what effect this policy is going to have on me as a person with a disability. So categorical exclusions based on the basis of diagnosis or functional impairment. So that is like the Alabama example. If they are identifying specific disabilities and deprioritizing you for care based off of those disabilities, that is problematic and that should not be done. Implicit or explicit quality of life assessments as allocation criteria. So that's baseline functional capacity. That could be explicitly stated as quality of life. Quality of life is a very, very problematic factor to be considered in a healthcare situation, especially for a person with a disability. And I do want to talk a little bit about that to explain that in a little bit more detail. The notion that a person with a disability may have a lower quality of life than a non-disabled individual is actually a fair concept. That is true in a lot of instances, and I'll give you an example of that. If you are a person that uses a wheelchair, you do not have access to certain buildings in the state of Michigan because the architectural standards for design under the ADA did not come into effect until I believe the 90s. Builds that were done before you gained those protections for architectural accessibility simply are not covered by the law, and you as a person that uses a wheelchair does not have access to that. That, I believe, would reasonably be interpreted as having a lower quality of life for that person. But what's important to note is not that the quality of life is less, it's how that quality of life is less. Because in that instance, society has imposed that negative quality of life on that person. And so if you were to use a quality of life assessment in making a determination of whether or not somebody was entitled to receive medical care, it would be so unfair for the person with a disability to have their quality of life considered because society has imposed so many burdens on people with disabilities that affect their quality of life that they're kind of getting dinged twice, that society has created a lower quality of life for you as a person with a disability, and based off of your lower quality of life, you are going to be deprioritized for medical care. And so it really hurts people with disabilities in two separate areas whenever you're considering their quality of life. And so you want to just avoid a quality of life determination. And what's more important is your ability to benefit from treatment and your ability to survive long-term based off of your individual circumstance. Another problem that we see in some of the policies around the nation is the prioritization of the young over the old. The general idea behind a guidance that would prioritize a young person over an older person would be that, as opposed to the goal being save as many lives as possible, let's try to save as many life years as possible. So in other words, if I save a 16-year-old as opposed to an 80-year-old, that 16-year-old will live longer. And so they should be prioritized because they have more life to live, essentially. So that's problematic because it pretty openly discriminates against older people who have some additional protection for themselves. But ultimately, the goal of a system should be to help as many people that can benefit from that treatment. And whenever you start to prioritize or deprioritize based on age, that has not only a negative effect on people with disabilities, because you're going to see disability being a more prevalent factor in people who are older than younger individuals. It would also devalue the life of older individuals in comparison to younger, which is problematic not only in a legal sense, but in a moral and ethical sense. An additional problem that can occur in the guidance is permitting reallocation on the basis of anticipated duration of need. So if based off of your disability, so say somebody who has mechanical vent use at home or uses oxygen at home, a doctor has concluded that you may need to be on a vent for longer than a baseline individual, somebody who does not use a vent for respiratory issues. That would be problematic because you should still have a right to an accommodation and a right to a modification of any policy that would ascribe any certain time period on your vent use. And so long as your accommodation is reasonable, then you should be entitled to that as a person with a disability. So for any policy that would identify somebody with prior respiratory issues as being deprioritized for the vent on the basis that they may have a longer duration of need, that would be inappropriate because you should be entitled to get an accommodation at a minimum from that policy. Ultimately, and again, you'll see me come back to this concept quite a bit, the key determination for the doctor to make is whether or not you can benefit from treatment. If you can benefit from treatment, then you should be able to access that treatment. The criteria that you can use to deprioritize folks should be a survivability criteria as opposed to things like quality of life or whether you're younger or what your need is. That if somebody is not going to survive for more than 1 year, it makes sense to prioritize somebody without those underlying symptoms and conditions that are going to cause that individual to die, most likely within the year, and prioritize based off of that survivability criteria, as opposed to taking somebody with a disability and under your preconceived notion of that disability or the stereotypes associated with it, you believe that you're going to have a low or a higher mortality rate on the basis of that diagnosis. That would be what would be problematic. So we're not saying that you cannot use diagnosis or disability as a factor in making a determination of where your priority should be. What we're saying is that it should not be determinative of you and that it should be done on an individual basis so that if you are, say a stage 4 terminal cancer patient, it makes sense to prioritize in that situation, but solely based off of your use of oxygen or a diagnosis of cystic fibrosis, for instance. You should not be deprioritized based off of those diagnoses alone. If the guidelines use short-term survivability probabilities, it must be done in that individual fashion, and it has to be relying on that objective medical evidence. So what we want to do is avoid guidance and policies that are going to negatively impact you solely based off of your diagnosis as a person with a disability or a pre-existing condition, and have doctors look at the objective medical evidence for you as an individual and making a determination of what your survivability would be if you were given treatment. And if you can benefit from that treatment and if you have a long-term survivability prospect, you should be entitled to that treatment the same as any other person without a pre-existing condition. So what should a medical rationing policy look like now that we've covered some things that are problematic with them? And I think that the most important concept that a medical rationing policy can communicate is what's the overall goal. So we talked a little bit about a goal of saving life years as opposed to lives. I believe that most disability rights advocacy groups and people with disabilities agree with this statement, is that everybody's life is precious and all lives are worth saving. And so if you operate under that principal concept, then you cannot deprioritize people based off of being younger versus older. You cannot deprioritize people based off of having a disability because everybody is equal and everybody's life is worth saving. And so another important concept that you're going to want to see in any policies or guidance is that individuals with disabilities are going to be entitled to reasonable accommodations and modifications, which are going to allow them access. So Jan covered a couple of examples of that, whether it's you need your service animal, whether you need a patient advocate to be there with you, or whether you deserve to have life-saving equipment. Reasonable accommodations apply to all of those determinations that are being made, and it is up to the person with a disability to ask for those accommodations and to do so clearly, especially in an instance where your life could be affected by the determination. And we'll talk a little bit about how to do that specifically in Michigan here towards the end. Decisions regarding resource allocation have to be done on an individual basis using objective medical evidence. Probably the most important principal concept to having a good medical rationing policy, that you cannot assign deprioritization to people based off of pre-existing conditions or diagnoses that they may have. You can consider those diagnoses in doing the individual assessment of that individual using that objective medical evidence in order to come to a conclusion on what your survivability likelihood would be over the course of 2 to 5 years. Most guidance usually use the survivability criteria somewhere within that range. If a doctor can conclude that based off of your medical evidence that you will not survive for more than a year, that is an instance where you can be deprioritized. However, if a doctor describes it solely based off of your diagnosis of cystic fibrosis or solely based off of your at-home oxygen use, that you are going to have a lower survivability criteria, that would be extremely problematic and something that you would want to avoid. So seeing things that mandate that individual assessment are important to having a good medical rationing policy at a hospital. If priority is in fact given to a certain group of people, there should be a rational basis for prioritization, and it must be done in a non-discriminatory manner. So I don't know of any guidance that actually does this, but this would be an example of something that I think would be legal to prioritize, and which is prioritizing your critical healthcare employees. There's a rational basis for that because in an event of a pandemic with limited resources, it makes sense to prioritize those who can help other people in that healthcare contact. And so if a doctor is diagnosed with COVID and there are limited life-saving resources of which the doctor needs, there is some sense to prioritizing that doctor because that doctor can in turn heal and assist in the larger societal issue of the medical rationing situation. We do not do this in Michigan. I don't know of any place that does this. I was just trying to provide an example of a non-discriminatory prioritization. And so this is something that is floated around conceptually and something that I believe would be non-discriminatory for folks with disabilities if we were to engage in a prioritization based off of that criteria. So what's our current guidance in Michigan? And I think Marianne's going to send around some of these links. This is about a 90-page document. And so what I did is I provided a link and then I identified the page numbers in that document that relate to medical rationing. This is your current guidance in Michigan. This is what hospitals are being advised whenever they're creating this policy. And I want to take a quick look at one thing that I find particularly problematic. And this is something that Jan and Marianne, myself, as well as some other folks on this call have written a letter to the state on Friday to address some particular concerns with this policy. But let me just highlight what I feel like is the main problem with this. So what you're seeing right now is a chart. This is found on page 71 of the previously cited guidance. Or this is the guidance the state is providing to hospitals to assist them in making a decision on who gets event and who does not get event in the event that there is a medical rationing or a limited there are a limited number of events in comparison to the number of people that need it. So you're going to notice there at the criteria at the top that you've got a low potential for death, and you've got an intermediate potential for death, and you have a high potential for death. And if you take a look at that criteria, what's probably the most concerning part of the guidance is what you're going to see there as the second note on the low potential for death. You'll see no severe underlying disease. So it gives a couple of examples of that, and a couple of these examples are problematic. So we talked about this, that solely based off of your diagnosis or your pre-existing condition, you should not be deprioritized on the basis of that. And so this chart appears to do that because if you have a severe underlying disease, that does not mean that you are going to die immediately or that you can't benefit from COVID treatment, but you are going to be deprioritized if you were to apply this chart to those specific individuals with severe underlying disease. So an example that they give here as far as the intermediate potential for death is a severe underlying disease with poor long-term prognosis and or ongoing resource demands. So they give the example of being home oxygen dependent or dialysis dependent, and you're unlikely to survive more than 1 to 2 years. So this is a little bit less problematic than the first category because it does place a survivability criteria. So if you are performing an individualized assessment of somebody that takes into consideration all of their healthcare information, not just the severe underlying disease, or into consideration the progression and the symptoms of that and how it applies to you as an individual, and a doctor forms a conclusion that you are unlikely to survive for more than 1 to 2 years if you were given treatment, then that would be an instance where you could prioritize and do resource allocation if the doctor can come to that determination. The problem with this policy is that it does not provide for that individualized assessment, and solely based off of your inability to be placed in a low potential for death, based off of a severe underlying disease, then this can be extremely problematic for folks that are coming into a healthcare system with pre-existing condition or a disability, especially one that may be regarded as severe because you'll notice that the examples are not limited. Whatever the doctor feels is a severe underlying disease is a little bit ambiguous. You have that, then you're immediately going to get dinged on this criteria and be placed outside of that low potential for death, which may affect your ability to get that life-saving equipment. This is problematic. And like I said, we are trying to address this particular issue with the state. Again, if you are in a situation where you need a vent, be considerate of your right to a reasonable accommodation, and specifically for folks with a severe underlying condition that do not have a prospect of being unlikely to survive in the next 1 to 2 years. This would be an instance where you could request a reasonable accommodation to allow you to be placed into that low potential for death if your objective medical evidence or medical records are going to reflect that you are not likely to die and that you can benefit from treatment, specifically the vent in this example. One of the portions of this I do want to point out is a SOFA score. So for those of you who don't know about SOFA scores, this is an assessment that gets performed in hospitals. This is used to determine mortality on individuals. There's a number of issues with sequential organ failure assessment that I won't get horribly into, but I guess simply put, I think everybody knows or has heard the story of the guy or girl who goes to the doctor and they say you have a year to live, and then 10 years later they're still healthy and happy, and the doctor was wrong essentially. That happens, and I think doctors openly admit that there's no exact probability or likelihood that they can guess whether or not you're going to live or die within a certain amount of days or years. That's extremely difficult to do. They use sequential organ failure assessments in order to try to assist them in coming to that determination. It's worth noting that the science is not perfect on this, and doctors can get this wrong. And so that's all the more reason to be considerate of your right to accommodation if, for instance, you have a disability or a pre-existing condition or an aspect of your care that may negatively affect you on a sequential organ failure assessment. So examples of that are at-home ventilator use. You're going to immediately get points. You're going to immediately get dinged for at-home ventilator use. Just because you use a ventilator in your daily life does not mean that you are not going to survive long term. In fact, the ventilator is what allows you to do that. Solely based off of the use of your ventilator, you should not be penalized if there aren't additional prognosis or diagnosis or symptomology that are going to suggest that you're going to have lower survivability criteria within that range of 1 to 2 years. You're also going to get dinged for pre-existing liver issues, pre-existing heart issues, and kidney issues. Assessment covers about 6 different areas of your body, so from respiratory, cardiovascular, hepatic, coagulation, renal, and neurological systems are all going to be looked at. For instance, folks that may have a delayed reaction, whether in your pupil response or in your muscle response, you could have a negative impact on your sequential organ failure assessment based off of that symptomology. But that symptomology may not be indicative of your long-term survivability. And so it would not be appropriate in that instance to use that criteria against you if it did not affect your long-term survivability criteria. So I think that the key takeaway is to remember that a person with a disability is entitled to an individualized assessment and reasonable modifications from policies and hospitals. So a use of a SOFA score without an individualized assessment on a person's short-term survivability can have a discriminatory effect and can be problematic. So if you are a person with a disability in a healthcare setting, if you are an advocate, if you are a family member, if you are a friend, be considerate of what the tools and what the guidance is to hospitals' medical rationing situations, and be considerate of what your rights are in that context. And I would advise you to request accommodations when necessary, whether that's to have a visitor with you or have somebody become a part of your treatment team, but also in consideration of some of these assessments and scores that may affect your prioritization on whether or not you'll be entitled to life-saving equipment in the event of scarcity. So I'm happy to answer any questions. I'll leave up information for my agency, final screen here, but I think that about does it for me.
Kyle, we have a couple questions here. I'm going to go through them. Jenny was asking if there was certain type of language that individuals that you could provide that would help them ask for these types of accommodations when they go to the hospital. What would your recommendation be?
So what I had said in the chat, Kyle, is that maybe we could put together some like boilerplate that we could get out to everybody of how you might write that in.
And I do not have boilerplate language for that specific request, but one thing that I would note is that you have, in Michigan, there's 2 separate laws that are going to give you an entitlement to that reasonable accommodation, and one is the ADA and one is the Michigan Persons with Disabilities Civil Rights Act. There's one important distinction between the 2 laws that's worth mentioning, and that's that the ADA is going to allow you to request orally for that accommodation, and that will be sufficient in making that request. However, in Michigan, you are required to request a accommodation in writing in certain instances. The best advice you can do is to do that in writing so you have documented proof of the request in any instance. I think that distinction between the laws is important because you may have a claim under your federal law and not have a claim under your state law in certain instances. As far as accommodations, I think that, specifically for the SOFA accommodation, to request that you not be scored any points on the basis of, say, mechanical vent use, prior kidney or liver issues that wouldn't have an effect on long-term survivability. Specific request would be to not, gain the 4 points that you would get solely based off of your mechanical vent use, because based off of your disability, your vent use doesn't relate to your survivability ability or your ability to benefit from treatment. So that would be what that would look like in the SOFA score, for instance. But ultimately, if you are faced with a situation where you are being deprioritized based off of your disability, that is the time when you need to figure out why you're being deprioritized and ask that question, and then request a modification from whatever policy reason they're citing for deprioritizing.
But just kind of going back to sort of like how you might write that, I will give some examples. I got your email, Jenny, and I'll shoot some examples of how we've written that for folks.
Is there any way that a disability can be taken into account without it being determinative? Any disability, it seems, or pre-existing condition for any given class, incoming patients, could be an existing class, implies a currency value of life expectancy, even if given on an individual assessment. Looks like any guidance along these lines violates the principle of equal protection under the law.
Yeah, and I think that's a very good question. I think that the key to an assessment and being non-discriminatory is not that you cannot take into consideration a pre-existing condition or that you couldn't take into consideration somebody's disability, but that you would be taking consideration of those aspects of the individual in the context of an overall assessment as to their ability to benefit from treatment and their survivability probability. So where it becomes problematic is where you would be deprioritized solely based off of having a certain diagnosis or having a certain disability, as opposed to taking that disability or taking that diagnosis into consideration of your overall medical record and coming to a determination of whether or not you could benefit from treatment based off of your entire individual prognosis.
Thank you, Kyle. And you might have already addressed this, but Jenny asked the difference between an accommodation and a modification to policy.
So the right to an accommodation is typically what it would be referred to, since that's the language of the law, but a modification to the policy would be the accommodation in that instance. So I guess I kind of use the terms interchangeably whenever it applies to policy, because you're asking for an accommodation, and that accommodation is the modification of the policy.
So can I, Marianne, just respond to Carolyn's question about the $2 increase for direct care professionals and also people not getting the hours that they need in their homes?
Sure.
Okay. So the Appendix K, so there is going to be this $2 increase for direct support professionals. The money for that will come from a variety of sources, actually, because Appendix K covers some kinds of Medicaid services, and there is another waiver request that I think went in end of the week, last week, that covers other kinds of Medicaid recipients. So direct support professionals are going to get the $2. It's just going to, and it's going to come out of some different pots of money that the state is requesting permission to use from the federal government for that. So your direct support professionals should expect to get the $2 increase. In fact, many CMHs have already got it started for folks. And then the other thing is if you are finding that there are medically necessary services that people aren't getting, you go through the same process that you would if we weren't in a pandemic, right? You have due process rights to get the medically necessary services that you need. So I would follow the same. If you're not getting access to safety supervision or assistive technology, you exercise your due process rights.